So the mechanics of breathing. Now, air going in, air going out, kind of two phases. One is called inspiration and expiration. And I've done it in the past, and I'm like, I've had a short answer question. It's not on your test. And I'm like, I've had a short answer question. I'm like, what's inspiration? And people are like, feeling inspired. No, and I'm like, inspiration, that's the first two words. It means air going in. Inspiration just means air going into the lungs or into the respiratory system. Expiration, and again, it doesn't mean it's past its expiration date. No. Expiration, X meaning out, is just air going out of the lungs. But there's several things that have to happen for air to go in and air to go out, and a lot of that all has to do with pressure. Now, atmospheric pressure, this is the pressure of the air around us. And I'm like, there is pressure in the air. The fact you were sitting here breathing in, like this air around us has pressure. It's called atmospheric pressure. Now, at sea level, and we're just going to pretend we're at sea level, and I'm like, we're not enough away from it to be significant. At sea level, atmospheric pressure, which we give it pressure with a little ATM, atmospheric pressure is 760 millimeters of mercury. I'm going to keep this up here. And I'm like, because I'm going to talk about it, how, we've got differences. Now, air going in and air going out all has to do with pressure changes. And I'm like, is it more than atmospheric pressure? Is it less than atmospheric pressure? Anything that's less than atmospheric pressure, meaning it is less than 760 millimeters of mercury. An example, if it is to 756 millimeters of mercury, that's less than 760. And I'm like, we would consider that a negative respiratory pressure. Now people are like, well, negative, it's not like I don't have a negative symbol in front of it. Doesn't matter. It's less than atmospheric pressure. So we call it negative. And then vice versa, if it's greater than 760, we call it a positive respiratory pressure. Zero respiratory pressure just means it's the exact same. It is equal to 760 millimeters of mercury. It's equal to the atmospheric pressure around us. Zero respiratory pressure doesn't mean there's no respiratory pressure whatsoever, because there is still pressure in the air around us. It just means it's equal to it. There's no difference. Now, there's two other important pressures. One is intrapulmonary, so a pressure with a P-U-L for pulmonary. Now, intra, what's intra mean? Means within. Within. Pulmonary means like within the lungs. This is the pressure within the alveoli. All those little things that look like grapes. And I'm like inside of your lungs. This is the pressure. This is air pressure in your alveoli. I'm just putting this up here. In alveoli. So it's in the lungs. Now, it will fluctuate with breathing, whether air is going in, whether air is going out, and we'll show you how that happens. But eventually, it will equal 760. So it may be a little above 760, maybe a little below 760. It just depends on whether air is going in or whether air is going out. But it should always eventually make its way back to 760. The other type of pressure, it's intrapleural pressure. It's a P with an IP for intrapleural. This is the pressure in your pleural cavity. So you've got your visceral pleura and your parietal pleura, and then you've got that space in between. That's your pleural cavity. There is a pressure in there. That little not empty space because there's fluid, but I'm like, but there is, in between that parietal and in between the visceral pleura, there is that cavity, and there is space in there. Pressure in pleural cavity. Now, this, oops, I can spell, is always negative. Always negative. Means it should always be less than atmospheric pressure. It should always be less than their pressure in the alveoli. Reason for it, and I'll show a picture that shows these different pressures. And I'm like, having this negative pressure in the cavity, it tries to hold our lungs open. If you have pressure in this cavity on the outside of the lungs, pressure squeezes in. That's not good. Squeeze in lungs. And I'm like, this negative pressure tries to open up and keep those lungs open. So there is some fluid in this cavity. I can't remember if my next picture. I'm just going to go ahead and I'll go back. And I'm like, you've got your intrapulmonary pressure. This is the pressure in your alveoli inside your lungs. Then you've got your intrapleural pressure, this pressure in this little tiny cavity. And I'm like, and we want this negative. Again, it holds the lungs open. It keeps them nice and, like pulling outward. And I'm like, so you can see it, it's pulling outward. Now, if fluid accumulates in here, because there's a space in here, if you have too much fluid in there, it increases the pressure. It might not be negative anymore, and excess fluid will push down on your lungs. It can cause your lungs to collapse. That's never good either. So if you start to have too much fluid in that cavity, that pressure starts to become positive instead of negative, and your lungs, that pressure and that fluid on the outside will push down on the lungs, and your lungs will collapse. We try to prevent that from happening. Now, there's a couple things that are going to cause this to always, be negative. There's opposing forces that are trying to push on your lungs, and there's other forces that are trying to push your lungs out and open. Now, the two inward forces that are pushing inward, trying to cause your lungs to collapse, but they don't. And I'm like, one is that your lungs try to recoil. They're stretchy. And I'm like, and they've got some elasticity. So when they open up, they then want to pull right back down. So that's trying to pull them back in. Also, and we're going to talk about surface tension a little bit, there is a surface tension in there as well around your lungs that tries to prevent them from fully expanding. It tries to keep them as small as possible. However, and I'm like, so that's like the bad news. It's trying to push in our lungs. The good news is that one big outward force enlarges the lungs. Our chest wall, and I'm like, the fact that we've got our ribs and we've got all of those muscles, and I'm like, and the lungs want to attach to it, and I'm like, that chest wall tries to expand that lung nice and big. And I'm like, so you've got one big, opposing outward force that tries to enlarge those lungs as physically possible, as big as they can get. Now, there's pressure differences. So if your intrapleural pressure is, I was going to say, if it's equal to your pulmonary, equal to your atmosphere, your lung collapses. It has to be negative. It has to be negative. There has to be a difference, negative Y, between that pleural cavity and either your atmospheric or your pulmonary. Now, the difference in these two is called our transpulmonary pressure. Now, our pressure in our lungs will eventually, it can fluctuate, but it eventually goes to atmospheric pressure. So we usually just say that pulmonary pressure is 760 millimeters of mercury. It's a horrible looking 7. Because it eventually equals out to that. Which means our intrapleural pressure needs to be less than that because it has to be negative. The difference in the numbers is our trans. Now, on average, this is 756 millimeters of mercury. What's the difference? What is 756 minus 760? -4. This difference, taking your intrapleural minus your atmospheric, this is -4. This is your transpulmonary pressure. Trans just means across. I can't spell today. And I'm like, it just goes across, between the two, between the lungs, between the cavity. What's the difference? -4. Now, the fact that that's a negative number, because our intrapleural is less. And I'm like, keep your airways open. The greater the difference, the larger your lungs can be. It's like it's trying to pull. The more difference, I'm like, if you've got a big difference, and I'm like, if this is more negative, it's trying to pull the lungs open as much as it physically can. So it's usually a difference of 4. If this is like -5 or -6, and I'm like, it tries to pull the lungs even larger, you can take a deeper breath. And I'm like, if this is not quite 4, it's like -2. And I'm like, it's still holding those lungs open. It's still a negative. It's just not pulling those lungs as big as they possibly can be. You just can't take as deep of a breath. So I'm like, but it has to be a negative number. If it's not, you can suffer from what's known as atelectasis, lung collapse. Your lungs will collapse. Now, there's a couple things that can cause lungs to collapse. That's really, it all is based on the pressures. One, you can have plugged bronchioles, which means now air can't get into the alveoli. If air can't get in, and I'm like, the pressure becomes too low in the lungs, and it will collapse. I'm like, you're not filling the lungs up. They will collapse if you don't get air in. This can happen sometimes when people have pneumonia. They get blockages in those bronchial tubes, and I'm like, and the lungs will collapse. Rare, it has to be pretty severe. And I'm like, also, you can have what's known as pneumothorax. You get air in your pleural cavity where you're not supposed to. So if all of a sudden you have air in this cavity, reason for that, you have some type of wound or some type of rupture, in case you get stabbed one day. And I'm like, now you just open up a possibility. There's now an opening for air to get in that pleural cavity. That is going to make it so there's no longer a negative pressure that's in there. It will cause your lungs to collapse. Or any type of, if there's a tear in it, occasionally air can go from lungs into it. It's pretty rare that would naturally happen. But if there's any type of damage, any type of wound, they can cause your lungs to collapse. How they treat it, they're going to put a chest tube in, try to remove the air that's in that pleural cavity. The pleura will heal, and naturally your lung will inflate. And I'm like, depending on how long it is and how long it's been, they might have to try to force it open, but your lung should re-inflate itself again. Now, moving air in and moving air out. Inspiration, expiration, air in, air out. It all depends on pressure changes and volume changes. Again, not the pressure. Pressure changes. Gases want to flow to equalize pressure. It's kind of like diffusion. Stuff doesn't like to be crowded. Air doesn't like to be under pressure. Same thing, if you blow up a balloon, I'm like, you were putting lots of air inside that balloon under a lot of pressure. Does the air want to be in the balloon? In that high pressure? No. And so when you open up the end of the balloon, where does all the air go? It all leaves. And I'm like, air wants to always go from high pressure to low pressure. Now, generally these pressure changes, and I'm like, we can change that because we can change the volume of our lungs. So when we change the volume of our lungs, we change the pressure, making air always go from high pressure to low pressure. Now, there are several laws. I think the only one we get through today is Boyle's law. No, the laws that have to do with the respiratory system. Now, Boyle's law has to do with pressure and volume of gas. And I'm like, just pressure and volume. They are inversely related, meaning if I have some type of gas and I'm like, we'll just say it's my balloon because I can squish a balloon. I don't have a balloon. And I'm like, but I blew up my balloon. Now, that's a fixed volume. It's already under pressure because it takes, a lot of pressure to push that air in there. However, if I can squeeze, if I can make that balloon smaller, what does that do to the pressure of the air that's inside of there? Because it didn't leave. It's still in there. If the volume gets smaller, what happens to the pressure? It gets bigger. So when your volume goes down, if your volume goes down, your pressure goes up. It's an inverse relationship, meaning opposites. Now, if the volume magically, my balloon got larger for no reason whatsoever, I didn't put any more air into it, but if my balloon decided to get larger, what will that do to the pressure? It would go down. And I'm like, inverse, they go opposite of each other. If the volume got larger, if my balloon all of a sudden just expanded, it got a lot larger, that's more room for that air to have. So it's not under as much pressure anymore. So it's an inverse relationship. Now, breathing air in is an active process. Active because it requires lots of muscles. Some of the big muscles we need to breathe air in, one of the biggest ones, our diaphragm. It's right underneath the lungs. We need our external intercostals in between the ribs. Now, at rest, I'm going to say, at rest, this is what your lung looks like. Lung at rest. Your diaphragm kind of likes to form a little bell-shaped curve at rest. Now, if I contract, lung contracting muscles. If all my muscles are contracting, my intercostal muscles and my diaphragm, first, the diaphragm, when it contracts, it flattens. Now, when my external intercostal muscles, the muscles in my ribs contract, they lift the whole rib cage up. What have I done to the volume? The volume has increased. My lung volume has increased. I've created this room. Now, what has happened to the pressure then? The pressure has decreased because they go in opposite. So I have low pressure. Now, an example of a low pressure, meaning it is less than atmospheric pressure. Just for numbers, 758 millimeters of mercury. Now, if outside the body, the air around you right now is 760 millimeters of mercury, where's air going to want to go? It's going to want to go in. If your lungs have a lower pressure than the air around you, air will go into your lungs. That's what's happening when you're breathing in right now. All you're doing is changing the volume of your lungs, which makes a pressure difference. Air naturally just rushes in. And you're like, but I feel like I'm sucking air in. Nope. And I'm like, you're just changing the pressure difference. And I'm like, I think my next slide, I'm like, there's some things you can do to even change, some more differences. But all you're doing is increasing the volume. Air will flow into the lung down its pressure gradient, high to low. That's all that's happening. Your breathing just changes volume, which changes pressure. Air rushes in. Now, there are some, other things, that help increase the volume. And I'm like, one, if you're doing vigorous exercise or if someone suffers from COPD, chronic obstructive pulmonary disorder, we get into that next time. And I'm like, we start to use other muscles that can really help puff up that rib cage. There's scalene muscles, your sternocleidomastoid, your pectoralis minor muscles. These are all muscles that further try to increase that volume to make that pressure even lower, like 755. And I'm like, that causes more air to go in. Expiration, so this was all muscle contracting. All muscle contracting to increase that volume. Expiration, we're just relaxing everything. It's a reverse. So it's a passive process. We're not contracting any muscles. All of those inspiratory muscles, your diaphragm, your external intercostals, they all relax, and we're going to reverse it. If we go back to relaxing, your diaphragm forms that bell-shaped curve. The chest cavity pushes back down on the lungs, and your volume now is going to go down. Now, when your volume goes down, what does that do to the pressure? Goes up. And I'm like, usually just above atmospheric pressure. Now, if this is 762, and again, still outside of 760, where's air going to want to go? It will want to leave. You didn't contract any muscles to make that happen. You just relaxed the muscles, and they made the pressure high enough in your lungs that air just wants to rush out of you. All you're doing when you're breathing is just changing the volume, which changes the pressure, and air wants to move in and out. Now, my little note, there is forced expiration. You sitting there just breathing right now, yes, air goes in, air goes out. But then you're like, but I really want to try to force out all the air in my lungs that I possibly can, which you can't force it all out. You can start to use other muscles and try to compress down your lung cavity. So you can use abdominal muscles and internal intercostals. So instead of just being like, you can be like, I'm going to try to breathe out everything you possibly have. Well, yes, you're trying to contract muscles you normally wouldn't. These are not normal muscles that are used for breathing, but they can help push out air. So that's forced expiration. But that's not what's happening while you're just sitting there, unless you're me. Now, 3 physical factors that influence air going in and air going out. So these are things that are going to hinder air going in. So the things that are going to slow down air from going in, and they all require energy to overcome. The first one is airway resistance. This big one, and I'm like, has to do with the fact that if you've got airway passages, and air has to flow along it. But anytime you have air rubbing against anything, even that's, the surface of those bronchial tubes, there's friction there that slows the air down. This is airway resistance. It's that, friction of air just rubbing against or going past those airway walls. Now, so this occurs all in your airways. My little formula, I will not ask you for a formula, and on an exam. It's just showing what happens when you increase resistant versus decrease resistant and their flow, and kind of it makes sense. And I'm like, this is looking at pressure, this is looking at flow, R is the resistance. If this is a really small number, if you have very little resistance, so air is not really rubbing past the inside of those airways, very little resistance, it can flow really fast through. Little resistance, this is a little number. When you divide by a little number, you get a big number. So I'm like, instead of dividing by 4 and you divide by 1, you get a really big number. And I'm like, if you have a little bit of resistance, you have lots of flow. If you have a lot of resistance, if you have to divide by a big number, you're going to have a decrease in flow. And I'm like, now, I was going to say, it's an inverse, increase in resistance, decrease in flow, inverse. Now, luckily, resistance isn't usually a big issue. It's usually insignificant. Yes, there is some drag there. Yes, there is some friction. However, your airway diameters are usually, really large. And so most of the air is not rubbing against the sides, not enough to cause a huge difference. And then as it starts to branch and they get smaller and smaller and smaller, and I'm like, you start to get more cross-sectional area. And I'm like, you just have more area for the air to spread out across. And I'm like, to the point where you even get to the very, very ends, when you get into those alveolar ducts, the end of the bronchioles, into the alveoli, then you have gas diffusion going high pressure to low pressure that's sucking air in. It's not even like our pressure breathing in is making it move. It's the fact that it wants to go where there's not as much air, and I'm like, into the body that's pulling that airway across. So it's not a big, but there is some drag, and there's some things that can increase resistance. I don't know if I had this one. And I'm like, things that can increase resistance. One, if resistance is too much, it's strenuous to breathe, and this happens for people. It's tiring to breathe. Now, and I'm like, this can happen if you have any type of obstruction of the bronchioles, they're smaller instead of being nice and large. It can prevent life-sustaining ventilation. Air can't get through. There's too much resistance, too much drag. This can happen for people that suffer with asthma. It constricts those bronchioles, and the air can't go through it anymore. There's too much drag on the outside of those bronchial tubes. Now, then, does anyone have asthma in here? Suffers from it? A couple people? And I'm like, and then if you suffer from an asthma attack, it's constricting those bronchial tubes. Then you take an inhaler. And you're like, I don't know, it's magic stuff in there. It's usually an epinephrine. And I'm like, dilates those bronchial tubes back open so that you have less resistance, less drag of the air going in. The second thing that can affect air going in is surface tension. Now, I'm like, let's see if I can draw. I don't know if I have blue. Now, surface tension, this is liquid molecules, and I'm going to use water as my example because we're water-based. Liquid molecules like to attach to liquid molecules when there is an air-liquid, interface. That sounds fancy. Here's water. Actually, I'm even going to make it a little wavy so it looks more like water. I don't have blue. There we go. There's water. Here's air. Woo. There's air. There's my gas-liquid interface. Now, where water reaches air, water wants to stick to water. It's attracted to itself. I'm like, they've got a slight positive, slight negative charge. They're attracted. Water molecules are attracted to water molecules, which allows bugs to walk on water. Have you ever seen the bugs in the summer, you know, that walk on water? Yay! It's because we're at water and air meet, and I'm like, there's enough surface tension that allows them to walk on water. They can't break those water molecules. Now, in our lungs, where we have all those little alveoli, our alveoli are coated in water. When you breathe in, and again, water is attracted to water. So like here's water molecule attracted to that water molecule, attracted to that water molecule. They're all attracted to each other. When you try to breathe in, they don't want to break apart. They like each other. And so your alveoli can't get larger because this doesn't want it to. It's like, no, we are here. We are going to surround this alveoli, and too bad if you want to get larger and try to breathe in more air and expand open. This is surface tension on our alveoli. This is not good. The fact that water wants to stick to water on the outside of our alveoli, it prevents those alveoli from enlarging and breathing. Instead, the fact that they want to stick together is really trying to push in on the alveoli, trying to make them collapse. However, we make a fluid called surfactant. It's a detergent-like fluid. Wish I had my colors. Ooh, I have red. That tries to break up. It tries to make it so the water molecules don't like each other anymore. And it starts to break up those water molecules. They're not attracted to each other anymore. If we can break up their attractiveness, it allows our alveoli to expand. We can breathe in. So it reduces the surface tension. They can't stick to each other anymore. Now, problem becomes infants, and I'm like, fetuses do not start making surfactant until the last 2 months, so month 7. Now, when is it that it's okay that if you go into premature labor, that if they're like, okay, you're okay, because what month are you in? If you're like, fine, if it has to happen, it has to happen. Hope not. I was going to say, it's right around month 7. And I'm like, again, weeks can be a little bit, you know, all right. But they're like, it's okay around month 7. If the baby has to be born, they're usually okay. Main reason is because right around then, they're making their own surfactant. If they are born prior to month 7, before month 7, they aren't making surfactant, what's going to happen to their lungs? Oh, it says it on there. Their lungs will collapse. Babies cannot breathe before that 7th month because they are not making surfactant yet. However, does that mean every baby that's been born before 7 months does? No. And I'm like, because now we've got medical technology. 1, they can put them on respirators to try to open up their lungs. 2, we also have synthetic surfactant that they can spray into their lungs to try to open up their airways. However, you know, they track those infants, you know, that have to have that done later on in life. They usually have some type of respiratory problems. You know, the respiratory system just didn't develop naturally on their own. They may suffer from asthma. They may suffer just from other, you know, respiratory disorders. But that's why it's that 7 months is so important. You're making surfactant. Lungs won't collapse. And the last thing that allows air to go in is called lung compliance. It's the fancy way of saying lung stretchiness. Lung compliance is how stretchy are your lungs. The higher your lung compliance, the stretchier your lungs, the easier it is to expand them. You know, whether you've got a nice, easy, stretchable rubber band versus one of those really tough rubber bands, the stretchier, the easier it is to breathe. So, and I'm like, luckily our lungs are pretty stretchy. However, some things that can happen to decrease their stretchiness, compliance, is if you have damage to lung tissue and it's replaced with non-elastic scar tissue. It's non-elastic, it can't stretch. As we age, and I'm like, and depending on respiratory conditions as they go down, we can start to make less surfactant, and which means it's going to be harder to stretch that. And if there's a decreased flexibility of your thoracic cage, And I'm like, if there's some type of damage, if you have some type of deformity to your thorax, you've got some type of broken something or it's misshaped, you can't lift, those lungs up. And I'm like, occasionally your costal cartilages, this is all the cartilage around your rib cage, they start to harden. Again, you can't lift it up, you can't stretch your lungs out. Or if your intercostal muscles somehow become paralyzed, rare things. And I'm like, but it will decrease that flexibility of your thoracic cage. You can't stretch your lungs up. Now, because of time, and I want to get you guys out of here so we start a little early, I'm just going to tell you all the answers, because if you've got all yours printed, you can just highlight. You ready? And some of these are from the intro video. One, the respiratory zone includes the alveoli. This is where oxygen, carbon dioxide is taking place. So respiratory is oxygen, carbon dioxide switching is respiratory. Conducting zone just means air is moving, is included in the trachea. No oxygen exchange takes place in the trachea. Air is just moving, conducting. Breathing air through the nose serves multiple functions. What function would be increased when breathing dry air? Is the fact that when we breathe it in, we humidify it. Occasionally, food or liquids go down the wrong pipe. What is the structural barrier that initiates a cough reflex? It's the epiglottis. Wasn't working correctly. Men tend to have deeper voices than women because their vocal cords are longer and thicker. The most violent coughing is initiated when foreign objects come in contact with the carina of the trachea, the little nubbin inside the bottom of the trachea. Which of the following is not part of the conducting zone? Conducting is just air is moving through, no gas exchange. And the alveolar ducts, there is gas exchange taking place. The respiratory membrane consists of the alveolar membrane, the capillary wall, we want blood, air next to each other, and the fused basement membrane that holds them together. It's called the respiratory membrane. How is it possible to remove a section of lung without damaging neighboring sections? Because lungs are actually, there's two of them. One, the lungs are comprised of multiple separate structures, each served with its own bronchus. I'm like, those bronchopulmonary segments. And I'm like, and the lobes and the bronchopulmonary segments are separated from each other from various connective tissue. They all have their own airway passages, their own blood vessels. The pressure in the alveoli. I got it up there. Intrapulmonary pressure just means within the lungs, in the alveoli. If transpulmonary pressure were to suddenly decrease, it wouldn't be -4 anymore. Predict the response by the lungs. Your lungs would collapse. You need that negative pressure to hold those lungs open. Air moves into the lungs during inspiration due to the force of atmospheric pressure. Pressure that makes air go in. Infant respiratory distress occurs because infants lack the ability to produce surfactant, which lowers your surface tension. Is that the last one? Almost? There is the last one. Yay! Let me stop.